Hi everyone. Happy Wednesday from Toronto. Dr. Amin here. We're going live. We're going live today with Dr. Alison Shea from Ontario, Hamilton, to talk all about women's health, longevity, how to stay young and healthy, strong, and age gracefully. So if you have any questions, as usual, I say just drop it in the comment or in the question bubble. And we try to go through them as many as we can today. It's a beautiful day here in Toronto, a beautiful spring day. I just give another minute waiting for everyone to join us, and then I'm going to invite Dr. Shea. Do not hesitate to put your questions here and let me know where you are today. Which part of the world? I always like to ask that question. I'm so curious to see where people joining us from here. Okay, let's see. I'm going to invite Dr. Shea. So I just send an invite, waiting. So whilst we're waiting, I'll just let you know that she's unable to join us. Dr. Shea is expert, menopause expert, OBGYN, gynecologist, and assistant professor at McMaster University. So if you have any questions, she is the person to ask about all those questions about menopause, hormones. As always, we have some technical. Okay, I'm inviting you, Dr. Shea. Unable. This happens a few times, and Dr. Shea, you just have to accept my invite. You will see the invite on top of the page, your page on Instagram, and you just accept the invitation. Yeah, I can see you here now. If you just accept the invitation. Let's see. We are both inviting each other. It's one of those technical issues that we always have. Invite. Mm-hmm. Mm-hmm. So whilst we're waiting, just let me know if you have any symptoms of transition, perimenopause and menopause, if you experienced anything, and if you have any concerns about those symptoms, and have you talked about those symptoms with your doctor. I love to hear you. Why unable to join? There we go.
Hi.
Hi.
Sorry about that. We were requesting each other.
That always happens. It's not you, or it's just some technical issue. I don't know. Hopefully one day Instagram can help us with that. So how are you? Great to have you here.
I'm great. I'm great. Was filming this morning for some sleep videos with a company who works in some sleep medicine, and so excited
Nice.
for that. So it's been a great day so far. How are you?
Good, good. I'm good. Thanks. Lovely to have you here. And we have so many questions about menopause, perimenopause, hormones. So let's just start. If you don't mind to introduce yourself, and for those who don't know you here.
Sure. So I'm Dr. Alison Shea. I'm an obstetrician and gynecologist and menopause specialist at McMaster University, based at St. Joseph's Healthcare in Hamilton. I did a menopause fellowship at Mount Sinai Hospital in 2017 with Dr. Wendy Wolfman. I also did additional training in that time in reproductive mental health. So I spent half my time with psychiatrists. And I'm a certified menopause certified practitioner. I'm actually the chair of their examination committee now. So overseeing the questions that people take every year to become a certified practitioner. And I'm on the board of the Canadian Menopause Society.
Wow, very busy.
Yeah. Very busy and always happy to share the word on menopause, and spread the love, spread the knowledge, and empower more women.
That's amazing. That's great. So what's the biggest misconception you hear about perimenopause, about menopause? And we wish that women knew earlier about or sooner about that.
Oh, there's so many, but I think probably the most important thing to know is when before your periods start changing, you can have some symptoms that are menopausal symptoms. And before your periods change, when they do start to change, is considered perimenopause. And there are a lot of changes that happen in our body, but often people don't realize that this is part of menopause. This is part of the hormones change. So sure, people know about, hot flashes, night sweats, but often sleep starts to change even before that. There are a number of hormone reasons for that. And there are many other things that happen. So we start to see changes in anxiety, changes in mood, some fogginess, and all of that goes hand in hand with the hormone changes. So it's really important for people to know that these symptoms start to appear, and people might think, oh, I'm just burnt out or I'm just tired, but it's actually hormones that are affecting us. And anything that feels different, if you're suffering, it's affecting your quality of life, then you deserve to get treatment so you can be feeling the best. And there are many safe treatments for many of the options. Some of them are hormones, some of them are not hormones.
Mm-hmm. So the common question I hear is how to then differentiate if this is hormone related or not, what to do and how to approach doctors.
So yeah, then that can be tricky for sure. The basic things you always want to rule out is to make sure there's nothing going on with your thyroid. Make sure you're not anemic.
Mhm.
Check your B12 levels if you're feeling different, because that can affect your memory and your cognition and your energy and your mood. So certainly that basic blood work. Once we get into the other hormones, it's tricky, right? Because we can't reliably test the reproductive hormones in the menopause transition because they're changing all the time. And so that's why we don't recommend testing your estrogen and progesterone levels, because what might look normal one day might be abnormal, 5 days later or the next month. And so often it gives us, not the answers we want. So just because it does looks normal doesn't mean you're not having symptoms. And so it can actually be invalidating if your levels come back normally. And so really kind of, look at historically how you felt. Certainly if there's any changes in your menstrual cycle, if you do still have a uterus, if they start to change, if it was typically a 28-day cycle and now your next one's 21 and then 32, any kind of change in the pattern, that should tip you off that your hormones are changing, because the cycles start to change, which is the hallmark symptom of being in perimenopause. So if the cycles are changing and something else doesn't feel right, there's a very high chance that it's associated with perimenopause or the change in hormones.
Mhm. So first, you want to rule out other possibilities and causes for that symptom, and if we can't find anything, especially if there are some cycle issues and irregularity, then there's highly likely to be perimenopause. So how early one can start or be in perimenopause? Your experience?
Yeah, I mean, the typical range, so the normal age of menopause in Canada is 45 to 55. And that's the time that it's been 1 year without periods. But the transition, to get to that other side takes anywhere from 4 to 8 years on average. So say you even go through menopause, you're on the earlier end of what's considered normal of 45, you could really be starting to get those symptoms in your 30s. And
Mm.
so, it's not uncommon that people go to their doctors and they're told, oh, you're too young to be in perimenopause. And when we actually look at the trajectory, many people can be suffering in their 30s. Certainly, considered early menopause before age 45, which is, up to 10% of women. And so you could also be in that younger bracket. What we consider premature or primary ovarian insufficiency is if that happens before age 40. But certainly if everything else looks normal, then, always a good idea to have that kind of in the back of your mind that it could be an early menopause if it does seem earlier than that.
Mhm. Right. And why some women have more symptoms compared to some who are very smooth transition? Why is that?
Well, that's a good question, and can be difficult to ask because there's not just one factor. So we know that certainly if you carry extra weight or if you have other medical comorbidities, things might be feeling a bit more difficult, like changes in sleep. If you have other comorbidities, can be compounded by the change in the hormones. We know that different ethnicities have different experiences with menopause. So we know on average, hot flashes last for 7 to 10 years, but on the furthest end of the spectrum are women with black skin, and on the shortest end of the spectrum are women of Asian descent,
Mhm.
with white women typically around 5 to 7 years. And so there's certainly ethnic differences that are at play. We know other things. So if you also have a history of any mental health problems, and you have a history of depression, then that's more likely to become prevalent again or become rear its ugly head around the time of the hormonal transition. So we know that if people have hot flashes, it's also an independent risk factor for depression. And so it's hard to kind of pull apart all the different things because there's so many things that are related.
Mm-hmm.
But many things, if they had bothered you before, may come to the surface again in the menopause transition.
Mm-hmm. Great. What about PMS? So we see more PMS or even PMDD during perimenopause. Some women experience. So how to deal with this problem? What do you normally, if you anything, prescribe women to help them with those symptoms?
So that's a great question too,
Mm-hmm.
is because a PMS and the severe form of PMS, which is premenstrual dysphoric disorder, gets worse before it goes away.
Mm-hmm.
And so I see a lot of people in my practice with premenstrual dysphoric disorder. So to the point that they are severely impaired in the luteal phase before their cycle. So either with depression, anxiety, irritability, or lability of mood. And of the referrals I get for that, I'd say more than half of them, certainly the majority, are people in their 30s and early 40s. And it's because the hormone fluctuations become more severe, you're going to get more severe symptoms. And so really, part of my job is really to validate that and explain that to women because they may not know that the symptoms are going to get worse. So certainly, first and foremost, validating that. And then treating them with a number of modalities. So we have a treatment approach in that certainly we want to optimize diet and sleep first and foremost. And there are some supplements and vitamins that actually do have some evidence for PMS symptoms. Those would be vitamin B6 at a dose of 100 milligrams. You want to optimize your vitamin D, start taking it if you're not already taking it.
Mm-hmm.
And there's some evidence for magnesium as well. And some people get results with another supplement called Vitex, which is from the
And
chaste tree or
someone
chasteberry.
is asking here about it
Oh,
too.
yeah.
Yeah.
And there are actually randomized control trials on
Mm-hmm.
that. So it's a great first step if you don't want to take prescribed
Mm-hmm.
medications. Um, you know, we also want to, make behavioral modifications in that, if you know that it's going to be a tough week and that week before your period, don't book as many things, and, just say giving yourself some space to say this is going to be a harder week. Let's allow myself to, not take on as much in that week. In terms of families, I often will recommend having a family calendar up and kind of highlighting when we expect kind of that rough time is going to happen. So for partners, to tip them off, say, hey, can you be a bit more gentle on me on this week? And, if they feel that your behavior is changing, maybe they can just, look up at the calendar and be reminded to be a bit more gentle and more sensitive during that time. If we do go towards prescription medications, the strategies are either to modulate the serotonin or modulate the hormones. And people come in and they, have different thoughts and feelings about what they want to do or what they've had experience with before. And there's no right answer. And the good news is that if the first thing doesn't work, we have many other options. So I tell people to always just be hopeful and optimistic because we have a lot of different things that we can try. So not to get frustrated if the first thing doesn't work. If we're going to think about, modifying the serotonin, if you serotonin medication, so selective serotonin reuptake inhibitors have worked for you in the past, then it might be a good time to try those. There is evidence to use those in the luteal phase, and the studies show that when you give them the luteal phase, that phase for your period or all the time, that they actually have similar effect sizes for PMDD. If we're talking about not the true PMDD or people who don't want to take serotonin medications, then we go to hormonal support. So either suppressing the hormones or supporting the hormones. So the easiest thing to suppress the hormones, particularly in the perimenopausal chaos, is to put you on a birth control pill. And so what that basically does is just shuts down the chaos, kind of gives you a steady state of hormones. The ones that have been studied are in the US, Yaz and Yasmin, but now we have a newer form of that, which is Nextstellis,
Mm-hmm.
which is a beautiful, my favorite go-to birth control pill because it's a natural estrogen with the same progestin that's in the yasmin. So that's a great first step, especially if you need contraception. Other things that we often use hormone therapy as well to support women's hormones. And so it's really, it's not the absolute levels of the hormones, it's the drop. And so when you're getting these peaks and troughs in your hormones, and if they're getting more severe, then supporting, giving you a background level of those hormones often can help buffer. So I say it's like wearing a life preserver. It's like you may still, jump in the water, but we're trying to keep your head above the water. You may still feel the waves, but we want to keep you safe.
It's interesting. I mean, some of my patients have that severe and that long. It's like a PMDD or PMS of 3 weeks, almost the whole month. So those cases, I normally go with the not cyclical, but on SSRIs the whole month, and they feel better. They really say it works better for us than going 2 weeks off or 2 weeks on.
Yeah, and
Mm-hmm.
that's my preference too. And it's
Mm-hmm.
really hard to also keep track. When should you start
Yeah.
taking it, and is your luteal phase the same every month? And often you realize once you're kind of in it, and so it's like kind of like already too late, like you've missed the boat. So I prefer for people to take them all the time. It's just easier, and then especially if it's more than that 2 weeks, it's just
Mm-hmm.
easier to take something every day.
Great. Thanks. What about hormones now? When do we start hormone therapy, menopause hormone therapy, that I mean, not birth control? So that's again another very common question I hear all the time.
So everyone has a different right age for them.
Mm-hmm.
And so one thing I will say is some primary care providers are more uncomfortable starting menopause hormone therapy when they're still in perimenopause, but the guidelines say that you can start it in the perimenopause. So if you have symptoms that seem to be related to fluctuations in the hormones, then especially night sweats, hot flashes, mood changes, all of these can be helped with menopause hormone therapy in the perimenopause. And so it's a great time to start. Certainly, if contraception or heavy bleeding is an issue, then often what we'll recommend is putting a progestin containing IUD together with a menopause hormone therapy estrogen so that you kind of mitigate, especially once you get that the chaos of the hormones often brings the chaos of the heavy bleeding. And you don't need another thing that's affecting your quality of life of having to run to the bathroom, soaking through pads and tampons before it goes away. Often it gets worse with these fluctuations in estrogen. So putting in a progestin IUD, if that's okay, something that you're comfortable with, is often what we recommend. And then it's really the rest of the time, it's whenever you have symptoms that you think can be helped with hormones. So certainly the on-label indications are moderate to severe vasomotor symptoms, which are hot
Mm-hmm.
flashes in the day and at night, and for the prevention of osteoporosis. So if you have a strong family history of osteoporosis, if you have risk factors, which many women have, having white skin is a risk factor for osteoporosis. Being a lower BMI, being thin is certainly a risk factor, and there are a number of other risk factors. Many other things. We know that in the perimenopause, that menopause hormone therapy can have similar effects on symptoms of depression as antidepressants. And so many people will prefer to take the hormones, particularly if they have other hormone related symptoms, to treat their symptoms of depression. And we know many other things get better. Often sleep gets better, aches and pains, joint pain often gets better with estrogen therapy. And I think there's just a lot that hasn't been well documented, but we're starting to see some of the research now with kind of some of these other symptoms. And I think in the next few years, we'll have a lot more data on all these other symptoms so we can have more evidence to recommend it for these other things.
Yes, hopefully sooner than later. So again, another question is always about any risk associated with hormone therapy, and are they, how do they compare to the benefits?
Sure. So for the most part, and for most people, the benefits outweigh the risk, like full stop. Certainly, if you started in that kind of early in perimenopause or that early postmenopausal window, there is a window of opportunity for many parts of your body. So a window of opportunity for your heart. We know that estrogen has some benefits for the heart if started in the first few years, ideally in the first 5 years, but up to the first 10 years. Beyond that, there can be increased risks for cardiac events or clots in the legs or in the lungs if you start it later. But it doesn't mean that you can't take it later. It just means you shouldn't start it later. I have many people in their 60s and 70s who are still taking menopause hormone therapy, but it's that constant stream of having that estrogen in your body rather than the stopping and starting, because we know estrogen dilates your coronary arteries. So if you take it after not being exposed to estrogen for a long time, that's what can be detrimental. In terms of the other risks, for the most part, most people can take menopause hormone therapy for up to 5 years without any real increased risk if you don't have a contraindication. Beyond the 5 years, if you're taking micronized progesterone, there is a slight increased risk for breast cancer, but that being one more case in 1,000 women. And so if you're mitigating your breast cancer risk by all the other ways, by not being sedentary, by keeping a normal BMI the best you can, by moderating your alcohol intake, all these things decrease your breast cancer risk. And the hormones get a bad rap for increasing the risk for breast cancer, when really there's all these other things at play, and many of the studies didn't look at these other things. And so that's what's important to know. If we think about taking oral hormones, oral estrogen, in somebody who would be at high risk for a cardiovascular disease or high risk for a stroke or a blood clot, we would prefer in these people to take a transdermal through the skin rather than an oral. By doing that, you significantly decrease the risk for any blood clots or stroke because it doesn't go through the liver.
Mm-hmm. Is it okay start year after menopause? How about starting at age of 60? How long we can continue taking hormones?
So yeah, so good, all great questions. So just because we say to start before age 60 or within 10 years of menopause doesn't mean you need to stop at age 60. Um, if you are 60, but you're still within 10 years of the final menstrual period, if you're over 60, then you're still kind of in that prescribing guidelines of 10 years after the final menstrual period. And so, I have people who are 63, 64, but they only just lost their period at 55. And so really you're still within that prescribing window. And if you're beyond that, it's been kind of just beyond the 10 years, then it's, a conversation between you and your doctor, and you may still be a candidate, but you want to do a whole risk profile. So they would want to look at your risk for heart attack, your risk for clots, your risk for stroke, look at your cholesterol, look at your sugars. All these things come into play when we're making these decisions. And it should be a shared decision making with your physician.
Yeah, it's very personalized,
Yeah.
as you mentioned. Do you mind just to go through different types of hormones that touch base on different types and how they work a little bit for everyone?
Sure. So if you still have a uterus, then you need to take an estrogen and a progestin. Most commonly, we recommend micronized progesterone, which is which is usually in a pill format. Together, the estrogen can either be through the skin with a gel, a patch, or a pill. Many people say that transdermal estrogen is the safest, but many people can take oral estrogens safely. And I think that there's a lot of confusion around this, and that if you are not at high risk for blood clots, strokes, and you have normal triglycerides, that oral estrogens can be the right option for you. And we actually know that oral estrogens actually improve your HDL, which is your good cholesterol. They decrease your LDL, which is one of the bad cholesterol, and they improve your glycemic index. So they decrease the risk for you getting diabetes if you're in that pre-diabetic role, in that zone. Other combination products that we have, which are also great options. So I love Duaviv, which is an oral estrogen, together with bazodoxifene. So the bazodoxifene is in lieu of the progestins. And what that does is it protects your uterus without giving you a progestogen or progestin. This is a great option for people who can't tolerate the progesterones. Some people who've had severe PMS or PMDD don't do well with progestins. Some of them do. They find it calming, but some of them don't. They have mood side effects from that. Some people also find the progestin bloating or causes them constipation or makes them too sedated in the morning. So it would be a good option for them. And we know also Duaviv is great for those who have a lot of breast tenderness or a lot of ongoing spotting and bleeding with menopause hormone therapy. So those are the two most common reasons that people stop hormone therapy, is ongoing abnormal bleeding or ongoing breast tenderness. And so the Duaviv actually is great for both of those symptoms. Also, if you're worried about somebody with very dense breasts, we know that this is a risk factor for breast cancer on hormone therapy. So if you have extremely dense breasts, then Duaviv would be a great option. Another great combo is Tibella or Tibolone, which is a one-stop pill, which is a precursor to estrogen, progesterone, and androgens. So that's a great option if libido is really a problem as well, because it can have that androgen side effect to help increase your libido, and studies show that it improves your sexual function. We have other combos. We now have Bijuva, which is a combo of estrogen and micronized progesterone in one pill. We've only really had that in the last year. So that's nice if you don't want to, play around with taking multiple things. You just want an easy one-stop shop and you want the benefits of the progesterone, and that's a great option for you. There are some combination patches, which I don't prescribe that often, which is Estalis or Estalis. The reason I don't like them is because they have certainly more reports, both in studies and anecdotal in my clinic, of breakthrough bleeding and ongoing abnormal bleeding. And so, it's annoying to have ongoing bleeding, and also you don't know when should we investigate. This is something we need to be worried about. So people get more ultrasounds, more biopsies of their uterus, and it can cause a lot of stress and anxiety.
That was amazing. So these oral estrogens are all synthetic ones. So none of these are bioidentical.
So no, so the Bijuva, which is the new combo product that we have, is 17 beta estradiol, which is considered, what your body would be making considered bioidentical or body identical hormones. It's just in an oral form. That's what the Bijuva is. And you can get that 17 beta estradiol on its own. It was typically called estrace, but now we have many of the generics available. So if you don't have a uterus and you want to just take the oral, then you could get this 17 beta estradiol or estrace. And that's easily available and has a lot of benefits. In terms of, yes, the conjugated equine estrogen is the estrogen that's in Duaviv. Some people don't like that because, for those who don't know, conjugated equine estrogen, or Premarin, is made from pregnant horses' urine. So Premarin, pregnant horses' urine. But at the end of the day, it's been around the longest and has probably the most data for it. And we know that those who took that type of estrogen in the Women's Health Initiative actually had less breast cancer if they didn't take a progestin. And, it was very safe for many women. And so it didn't seem to increase a lot of risks. So even though, the thought of that can, be a bit off-putting, it's tried and true and been around very long. So it has a lot of safety data behind it. So that's what's nice about it, is because we have so many years of data.
Very good. And again, another question is about women who have high blood pressure, controlled high blood pressure with medication, and high cholesterol on statins. Is it safe to take hormones?
Oh, yes. So certainly if you have controlled high high blood pressure, if you are, it's being followed by your primary care provider, your nurse practitioner, and you're checking it and regularly, and it's within target, then you can basically take any form of hormone therapy. If it's not the best controlled, you may want to consider transdermal estrogen, and that's because there are some studies that show that when you give the estrogen through the skin, it actually can improve your blood pressure. But if it's not well controlled, you would want to stay away from an oral. In terms of the cholesterol piece, so really important question, because if there's a few different things we look at in the lipid profile. So there's a few of the bad ones, which is triglycerides and LDL. And so those ones we don't want to be high. Transdermal doesn't do anything to any of your cholesterol, but oral can improve the LDL, the bad one, but it can worsen your triglycerides and then put you at higher risk for heart disease because of that. Also, if you have a history of gallbladder disease and you still have your gallbladder, we wouldn't recommend an oral estrogen.
And what point, if any, you check the levels of hormones? I mean, we hear sometimes some of women see doctors, and every 2-3 months they have blood tests. Is that recommended, or should we check the levels when they start hormone therapy to see if, or just go with the symptoms?
Yeah, we go by the symptoms most of the time, because because your blood test tells you something, but you're still having symptoms, if you're, wouldn't mean that we wouldn't want to increase your levels. If we got to a level that was kind of at the upper end of what we would prescribe, then we may consider checking a level. If the question is, can I go on a higher dose? So, if we're looking at levels for a postmenopausal female, generally what we would, if we were to test, you'd want it to be the 100, 200. You try not to get up to the 300, 400, because that would be a higher level than your body would be used to. But we don't routinely check, because there's really no value that means that that it's enough for you, right? And so it's just when we're getting to super high levels. When we may test is if, again, if you're not responding. If you got to a high level, again, and we're saying like, okay, you feel like you're still having symptoms, let's check the levels. And if they're at a higher level, we'll say, okay, well, we don't want to go too much higher. Or if they're too low. So it's not that common, but there's probably about 10% of women who, for whatever reason, they don't absorb it well. And so if we're kind of increasing the dose and then they're still having a lot of symptoms, then that would be a reason to check. So it's either they want to go higher and they're already at a high level, or we're increasing their dose and they're still having symptoms. And so there might be something about their own metabolism that they're not absorbing it well. And for some women, what we see is with the transdermal approach, for some people, they don't absorb it well, and in those people, we have to switch to oral. For the most part, the majority of people get a better absorption through the skin, but it's not for everyone. So it's really, if you're not responding, because otherwise, it can be, variable, especially if you're taking oral. It can be variable between what you ate, what other interactions you have, what your day was like, what time of day it is, how full you are. There's just so many things that can contribute to it. So we don't generally recommend unless you're kind of at either end of the spectrum.
And what about local estrogen for vaginal atrophy? What are the types available here in Canada, approved and available for women?
Okay, great question. I just did a reel on this last week, so I urge you to go to my channel. I gave grand rounds to our department here at McMaster for what we call the genitourinary syndrome of menopause. So that's the changes that happen with hormones in the lower urinary tract, the vagina, and the vulva. And we have many options. What's great is that we have a lot of options. And things that have been around the longest are things like Premarin creams in the vagina, which is tried and true and works very well, but it has a rose scent in it. Some people don't like that, and some people don't like the messiness of the creams. Uh, what's been around quite a while now is Vagifem, which is the estradiol tablet, which I am using less and less of unless somebody's asking for it. And there are a number of reasons for that. What I don't like about Vagifem is it's a single-use applicator. That blue plastic applicator, there's a lot of waste, and a lot of people find that applicator scratchy.
Yeah.
And then often, because it doesn't dissolve as well, it's the least messy, probably, but it kind of has this chalky kind of feel that doesn't absorb well in some vaginas. And it also doesn't seep out and get to that opening area. Right at the opening of the introitus is where 80% of women have pain with sex, that opening. And so it doesn't seep out to get there. So I'm using that less and less. My favorite right now is Intra Rosa, which is prasterone, which is also DHEA. It's a suppository. You use it every day, and it's in a coconut oil base. And it's nice because it has the coconut oil moisturizer, but it also has the DHEA, which breaks down into an androgen and to an estrogen inside the cells of the vagina. And then some of it comes and coats the outside. And so it helps the clitoris, it helps the labia, it helps that opening. And we know a lot of people have pain there, and there are pain receptors that it gets a lot better with the Intra Rosa. In lieu of Vagifem, I'm recommending Imvexi, which is a 17 beta estradiol gel cap. It's only been about a year and a half now, I think we've had it in Canada. There's no applicator. It melts away inside the vagina a lot better than the Vagifem. And if you are covered by the Ontario formulary, if you don't have a private drug plan, or if you're on the over 65 drug plan, it's great because it's covered, and there's much less waste. But there are still people who aren't comfortable putting something inside their vagina. And for these patients, we have an oral option to help their vaginal symptoms, which is something called Osphena or ospemifene. It's hard to say.
It is.
Yeah, but it's an oral tablet, and there are really good studies on that. So if it's not covered under the formulary, unfortunately, but if you're not comfortable putting something inside your vagina, then this would be the right option for you.
There is estrogen as well. Is it estrogen?
Oh, yes.
Which is estrone.
Estrogen.
That's
Yeah,
the
estrogen, which is
cream.
estrone.
Which,
Yeah.
I normally not prescribe. I've seen a few times. And interestingly, we did the hormone levels on this woman who just was on local estrogen, which was estrogen. And she had quite elevated, like she's on systemic estrogen. So it was very unusual. It was very unusual.
Oh, wow. Yeah, no,
I don't know if you've had such experience with this specific medicine.
No, I
Or
haven't.
hormone.
That's interesting because it's supposed to be a less potent one. But yeah, I'm not using it that much. I used to, but I'm not using it that much now because a lot of people just find the creams are messy. So with these newer kind of suppositories and gel inserts, I find that people are enjoying those much more. Yeah, interesting.
Yeah, it was very unusual. So I stopped. We
Yeah,
decided to stop.
fair enough.
Yeah, it was very unusual. So what about for people who don't want to use hormones? Before we go there, I just want to have your comment about testosterone. We hear so much on social media, everywhere about testosterone. Here in Canada, it's not approved for many different reasons, or for many different symptoms of menopause. So if you just tell us a little bit about testosterone.
Yeah, so tons of menopause influencers are talking a lot about testosterone, and it's great. It's great that we're talking about it and we're getting the word out. It is considered a normal female hormone that does start to decline more gradually. So it does start to decline even in your late 30s, your 40s, and then worse in your 50s. And is involved in many things in our body. So certainly our sexual response cycle and our desire testosterone is very important for that. And that's why people who have surgical menopause, if they've had their ovaries removed, they have much worse sexual function and libido, because even after menopause, we still get little bits of testosterone from our ovaries. So the loss of those ovaries can have a dramatic effect on our sexual function. So certainly testosterone therapy is, there's a 2019 global consensus statement that was endorsed by 20 societies worldwide, and that's for the sexual function, that there are good randomized controlled trials showing the benefit of testosterone for sexual function. That said, there's a lot of emerging interest on testosterone for many other things, and that would be effect on mood, effect on cognition, and effect on bone health. And certainly there are some studies showing that it improves these things for some people. The problem with some of the studies is some of the studies aren't huge studies, and some of the studies, the effect was not significantly different than the placebo. And so it may help you, but at this point, we don't have solid data that improves it for the majority of people. But nevertheless, it's still worth a try. So, that's what I'll say, is that it may help you for your brain function. It may help your mood. It may help your energy. The studies are mixed. Hopefully, more and more studies are being produced. The world leader in testosterone is Professor Susan Davis. So you can follow her on Instagram. She's done the most testosterone studies in the whole world. And so she's a great resource for that. And so it's not that it's not going to help these things. It's not a slam dunk like it is for sexual function. So I tell people, hey, it's worth a try. If you want to try it for these other symptoms, why not?
And we still don't have anything for women, do we? I don't think we have any preparation for women.
No, I think the UK, oh no, not even the UK. I think Australia is the only place that they have a female product. And I think that's largely because of Professor Susan Davis, because she's pushed it forward and advocated for women. So we'll get there. It's considered an off-label use, but so many things we do in medicine are off-label.
Yeah, I mean, for even menopause symptoms like gabapentin is a nerve medicine, but we do off-label use for.
Exactly.
So, and then for women who do not want to go on hormone therapy, what are the options, and lifestyle or any supplements you talk to the patients about?
Certainly. So it certainly depends on their symptoms, right? And so if they don't have hot flashes and they don't have the other symptoms that we would suggest are related to, low estrogen, but they might be having, problems with their mood or problem with their sleep, then certainly we have many good medications for that. Other things we will always want to optimize. It's a great opportunity to say, like, hey, how can we improve our sleep? Sleep gets worse for the majority of women, even starting in perimenopause. Yeah. So there are a lot of things we can do to optimize.
Myself.
Yeah. And so, cognitive behavioral therapy for insomnia is the gold standard treatment. And if you have benefits, then certainly to get therapy for that, and has long lasting benefits. So, I always have to put a plug in for that. Optimizing your sleep routine, looking at things you can, avoid before bedtime, certainly a good idea. We know that we're more sensitive to changes, the changes in light before bed once we get to perimenopause, and that's with our own changes in melatonin. And so any kind of backlight, scrolling on your phone, the computer, when our melatonin levels are already going down, suppressing those even more with any bright light is going to make things worse. So paying attention to that. In terms of, supplements and vitamins, some people get, certainly melatonin supplementation can help for many women. Magnesium supplementation can help sleep for many, many women. And other supplements and vitamins, again, it depends on your symptoms. So supplementation, and because there is much emerging evidence, not just for building muscle, but also for energy levels for women and for cognition. So there is good evidence now that creatine supplementation can improve mood scores and can improve cognition and kind of brain fog symptoms, because it helps to your body utilize energy better. And once you get to perimenopause and menopause, your brain uses a lot of your energy, especially if you've got some brain fog. You're having more and more energy utilization by your brain, and so creatine has been shown to help with that. From what I have heard and read, some people do better with creatine hydrochloride versus the monohydrate. The monohydrate is much cheaper, but it can cause bloating for some women. So if that's already an issue for you, then you would want to stay away from that. Other supplements and vitamins, certainly everybody should be taking vitamin D. Make sure you're getting calcium in your diet. And there is some good evidence for omegas as well. So the fatty acids, those are important. And other supplements, if I guess we can consider fiber a supplement. It's important to get enough fiber in your diet. Make sure you get enough protein, but that's not really a supplement. And the other supplements, the data is more mixed, so it can be difficult. But we have a lot of great non-hormonal options for your symptoms. We now have Veoza or fezolinetant in Canada, which is the first on-label treatment for hot flashes, which works at the level of the brain. It's now available to prescribe for women if you can't or don't want to take hormone therapy. It's a great option. And then certainly gabapentin, SSRIs, oxybutynin for overactive bladder, also can be used for hot flashes.
Great. Lovely. It's great. Any last recommendations for the viewers here today?
Really, if you're not getting the help that you need, what I would urge is, certainly do your reading, but a good tool is to go to the Menopause Foundation of Canada has a symptom tracker. You can download the symptom tracker or print it out, look at the symptoms, see if these seem like your symptoms, bring this to your doctor, but do some background reading. So the Menopause Foundation of Canada will direct you to great sites that are evidence-based and say, I've got, these are the symptoms I have. I think they're related to perimenopause or menopause, and these are the options. I want to talk about this as an option, because often, you only get 10 or 15 minutes. And so you want to, capitalize on that time, come prepared. And if you're still not getting the help that you need, then certainly to ask to be referred to a provider who will listen to you. And you can find links to that on the Menopause Foundation of Canada. And there are many more people that you can come see, maybe like yourself, that can see them and help them. Not everybody needs to see a menopause specialist per se, because we all have really long wait times. I have an 18-month wait time right now. Mount Sinai has 2 years. And so most people don't need to see them. They can see if their primary care provider can't provide them, they can look elsewhere, or they can just ask for a referral to a gynecologist. And if they can't see them, hopefully they will suggest you to go to someone who can help you. But just to advocate for yourself, if you're not getting the help you need, you don't need to suffer. It's a rough and bumpy time for many women in the perimenopause and the early menopause transition. But once you get to the other side, then things get a lot better. And I will just a few more snippets from the Lisa Moschini, the Menopause Brain. I will urge people to read that. Yes. And she cites studies of women in their 60s rate their quality of life as much higher than women in their 40s and their 50s. I think once the dust settles, that we have a good new happiness. And she also said that even though women's processing speed slows down in the perimenopause and early postmenopause, our brains still function faster than men's.
Well said.
So we're doing just fine.
It was lovely chatting with you today. Thanks for being here with us, and hopefully I see you in person.
Excellent. Lovely working with you.
Take
Have
care.
a nice day.
Bye, everyone. Thank you.
Thank
Bye-bye.
you.